Hey, hi all. Good afternoon. Happy
Good
Janmashtami. And first of all, I would like to welcome you all for the next session. And Reshma ma'am, a warm welcome for you.
Thank you.
And I'm handing over to Anisha ma'am to introduce our faculty.
Hi, good morning. So today our topic is care of bedridden patients by Reshma ma'am. Reshma ma'am is already known person to us. She took the class of subcutaneous infusion. So Ms. Reshma ma'am has a section head for home care nursing services in Palliative, India. She has completed her BSc nursing from Smith College of Nursing and completed CCPN course from Palliative, India, and she has been associated with Palliative, India since over 5 years. So welcome ma'am, welcome for this session.
Thank you. Am I audible? Am I audible?
Yes,
Yes,
ma'am.
ma'am. Yes.
I think my screen is visible, right?
Yes, ma'am.
Okay. Okay. Good afternoon to all. Just a minute. Just a minute, ma'am. Okay. Today we are discussing about care of bedridden patients. As we know, most of our palliative patients are bedbound. Mainly, some of them are in the starting stage and at the end of their life, they are in bed. But when they are admitted in a hospital, there are lots of person like doctors, nurses. They are taking care of them. But once they discharge to home, it is very difficult to manage them in home care settings. So it is very important to teach the caregiver how to take care of a bedbound patient when they are going to home after discharge. So today we are discussing about all these points and what are the principles in caring of a bedridden patients. In that, we are main principles include it is to prevent health complications. What do you mean by prevent health complications? Any idea? What are the expecting complications of a bedridden patients? Any of you?
Pressure sore.
Yeah, but very good. Pressure sore is the major complications that we are expecting for a bedbound patient. So to prevent these type of health complications, it is very important to give a caregiver education to the caregiver regarding the care of bedbound patient. And next one is to promote comfort. It will, if we are caring the bedbound patient properly, it will promote the comfort of the patient and it will build confidence and prevent isolation. We know if so in some of the bedbound patients, they will not receive any proper oral care at right times. That may lead to a formation of halitosis and sometimes candidiasis may cause. So if the patient is having halitosis and all, and if there is any foul smelling wound, and if we are not taking care of it properly, it will cause isolation for that patient. And these all aspects include improve the quality of life. The main principles of caring a bedbound patient is mainly focused on the improving the quality of care. And what are the basic needs of a patient? What are the basic needs? The patient is bedbound and he can't do anything by himself. So we should give special attention from the head to foot. So the basic needs include from oral care, skin care. We should give special attention to these points. That is, we should give oral care, then skin care, eye care, ear and nose care is very important, hair care, perineal care, and nail care. These are the some of the highlighting points in what we are discussing. And first, we are discussing about the oral care. Oral care means the overall health of the patient. Oral care stands for the overall health of the patient. The main purposes of oral care, we know the mouth is an excellent incubator of growth of bacteria, and if we are not treating it properly, it may cause to develop several infections. So the main purpose of the oral care to help to maintain healthy status of the mouth, teeth, gum and lips. This is the main purpose of the oral care. And through oral care, we are aiming to remove the food particles that may be likely medium of bacterial growth. The patient can't able to remove by himself, and if there is any food particles remaining in the oral cavity,
Ma'am, are you sharing PPT? It's not visible actually.
okay, just a minute. It's not visible. Just a minute. അല്ല PPT visible അല്ല ഇതില് Is it visible now? Is it visible now?
Yes, ma'am.
Okay, okay. We are discussing about the oral care. And we are the main purpose of the oral care is to remove the food particles that is remaining in the mouth after a feed or oral intake. Otherwise, it will cause bacterial growth. And the other main purpose is to keep the lips and mucosa soft, clean, intact, and moist. We know some of the patients will develop dry mouth due to some medications and all. So, if we are not giving mouth care properly, it may lead to cracked lip and other complications. So, to prevent this, we should keep the lips and mucous membrane clean and intact. And the other purposes include to promote comfort and improving nutritional status by enhancing appetite. If the patient is not getting adequate enough oral care, that there is a chance of developing candidiasis, dry mouth, like mucositis and all. So to avoid these and to promote comfort, we are giving oral care. And while doing oral care, we are using, sometimes we are using soft toothbrushes, and it will stimulate the blood circulation of the gums thus maintaining a healthy firmness and eliminate, we can able to avoid halitosis. And what are the main oral problems that we are usually seen in palliative care, or if the patient is on inadequate oral care, what are the common problems? Any idea? What are the common oral problems that we are seeing in palliative care patients? There are so many oral problems.
Foul smelling, dental caries,
Yes, halitosis, dental caries. Anything else?
s- uh,
Okay, some of the common oral problems include dry mouth. Dry mouth usually, if the patient is taking any opioids, it is a side effect of dry mouth. Oral dry mouth opioids is dry mouth, and sometimes it may be painful, and there is a chance of developing halitosis, candidiasis. It is very common in palliative care patients with immunocompromised patients, mainly candidiasis. Then oral mucositis is very common, and these may lead to alteration, taste, and some may experience excessive salivation. And first, we are discussing about this xerostomia. Xerostomia is commonly called as dry mouth, and it is a condition characterized by a noticeable reduction in saliva production, and it will leading to the persistent feeling of dryness in the mouth. Xerostomia means dry mouth. It is usually happen due to the decreased production of saliva. And another major problem is candidiasis. It is one of the major oral problem with cancer patients because they have low immunity system. In candidiasis, candidiasis may lead to esophagus also, and candidiasis of the mouth and esophagus is commonly known as thrush. And if the patient is suffering from esophageal candidiasis, mainly these are caused by the fungal infection. This is a fungal infection mainly affecting the oral mucosa. And oral candidiasis presents as you can see white patches and creamy lesions on the tongue. And we can see it in the inner cheeks and sometimes the roof of the mouth. And while esophageal candidiasis can cause painful swallowing, if the patient is suffering from oral candidiasis, there is a chance to spread this oral candidiasis to the esophagus also. If the patient is experiencing swallowing difficulty, that is indicating to the patient is having esophageal candidiasis. And it will cause painful swallowing, dysphagia. Patient may experience dysphagia. And these infections are more common in individuals with weak immune system. This is mainly in patients with weak immune system. So we discussed about xerostomia or dry mouth. Then we discussed about the common oral problem in our patients is candidiasis. And next one is halitosis. As we said, it is a bad breath. It is otherwise known as bad breath. And it is a condition characterized by an unpleasant odor from the mouth. And it can be sometimes lead to social embarrassment and may lead to anxiety or social isolation. If the patient is not getting enough attention for oral care, there is a chance of developing halitosis, and it will lead to social embarrassment and even lead to anxiety or social isolation. And this condition can stem for various factors, including it is maybe due to poor oral hygiene. Then some of certain food materials may cause halitosis. Then if the patient is having dry mouth, there is a chance to development of halitosis. And if in some underlying medical conditions also patient experience halitosis. And next one is the mucositis. It is very common in cancer patients, and the mucositis refers to the inflammation or you can see the inflammation or ulceration of the mucous membrane, which are we know mucous membranes are the protective linings around, from the of the digestive system. From oral cavity to the anal cavity, we have a mucosal membrane. And the primary cause is the cancer treatment. Mainly the mucositis is commonly seen in patients with cancer treatment who they are receiving chemo and radiation. These are the main oral problems. First one is we discussed about the xerostomia or dry mouth, and candidiasis we discussed, then halitosis and mucositis. And next is who needs mouth care? Who needs mouth care in commonly who needs mouth care? Any idea? Who needs mouth care?
Everyone.
Bedridden patients.
Ma'am? Okay. Who needs mouth care? If the patient is terminally ill, they need mouth care. We know in terminally ill patients, sometimes they may experience mouth breathing. There is excessive secretions there. So the terminally ill patient need special attention for their mouth care. And for unconscious patient, the patient is unconscious and they can't able to take care themselves in oral care. So they need special attention. Then patients breathing through mouth. In some conditions, there is mouth breathing is there. So that type of patients need more attention in mouth care. Then some post-operative patient, we know in post-operatively, the gag reflex is less. So they need our assistance in oral care. Then patients with infections and diseases of the mouth. In oropharyngeal cancer, in oral CA tongue, like that situations, the patient need additional attention to their oral cavity. And then in patients on nasogastric tube feeding. Okay, what is the importance of giving nasogastric tube oral care to nasogastric tube feeding patients? Is it important? Why we are giving oral care for nasogastric tube feeding patients? We are not giving anything orally. We are only administering food and medications through rice tube. Then why it is important in oral? Why the oral care is important for them? Any idea? Because if the patient is not taking anything orally, means, but it doesn't mean they doesn't need oral care. If the patient is on nasogastric tube, we should give oral care every 2 hourly. Ideally, it is every 2 hourly we should give oral care for a nasogastric tube patient. If it is not possible, the caregiver should train to give oral care at least after each feed. At least after each feed, the caregiver should give oral care for the nasogastric tube feeding patients. So these are the main category of patients who need additional attention for oral care. And what are the points you will assess before starting a oral care? Because the assessment points include, we should assess for any cracked lips. Is there any cracked lips or dry or clotted tongue? Is there any white curd-like patches? If there is the presence of white curd-like patches, means the patient is suffering from candidiasis. So is there any ulceration in the mouth? You should assess that also. Any redness or bleeding? If the patient is having any redness or chance to bleed, you should select a soft toothbrush or a cotton gauze like that. So the assessment is very important. If there is any redness or bleeding is there or any pain in the mouth, it is very important. If the procedure is painful, it is difficulty to tolerate the patient. So while assessing, you should assess that if the patient is having any pain in his mouth. And dysphagia, we already discussed in candidiasis. If the patient is suffering from esophageal candidiasis, there is a chance the patient may experience dysphagia and will lead to change in the taste of food. So while assessing, we should assess if the patient is having dysphagia or not, or any difficulty in chewing. And anorexia, we know anorexia is the loss of appetite. It may due to it may be due to some physiological factors and all. So you should assess on that also. Then unpleasant smell. If there are any food particles remaining in the oral cavity will lead to unpleasant smell and halitosis. Sometimes some medications may cause halitosis. So while assessing, if there is any, if we noticed one unpleasant smell, you should check the medication history, and if the patient is having any medications that will lead to halitosis, like that you should assess. Sometimes dry mouth can cause halitosis. So these all things you should assess. That is the medication history. It is very important. Some of the medications cause severe impact on the oral cavity of the patient. Then treatment history. It is also very important because the immunocompromised, if the patient is regularly taking chemo and radiotherapy, means the patient is immunocompromised, and there is a chance of developing mucositis, dry mouth, and all. So these are the main assessment points. While assessing, we should assess for the cracked lip, dry or coated tongue. White curd-like patches means the patient is suffering from candidiasis. And is there any ulcer, redness, or bleeding? If there is any pain, you should give attention to the pain first, then to the oral care. Then if there is any dysphagia, that means patient is suffering from esophageal candidiasis. And any difficulty in chewing, anorexia, unpleasant smell, medication and treatment history. And solutions used for mouth care. We know in hospital setting, we are normally using 0.9% sodium chloride for oral care. But if the patient is in a home care setting or a rural area, we can advise or instruct them to make homemade salads. Next is how we are going to prepare homemade salad. Take 500 ml of water, add 1 teaspoon of common salt, boil it, then cool it and keep it in a clean container. We can use it for maximum 5 to 7 days. We can use according to the need only we are preparing. Ideally, we are taking 500 ml of water and add 1 teaspoon of common salt. Make it boil and cool it and keep it in a clean container. While doing mouth care, instead of sodium chloride, we can use this homemade saline. And there are some alternative methods also. If soda bicarb is available, take 500 ml of boiled cool water, warm water, and add quarter teaspoon of baking soda. We can use it as a mouthwash. Ask the patient to gargle it. Usually, we are giving for ICU patients. We are giving oral care every 2 hourly. At least we should give care after each feed. So, if the patient can gargle, then ask them to use these solutions. And the self-care education is very important. Self-care education include tell the caregiver and patient to brush the teeth twice a day. If the patient can do it by himself, he only need assistance of the caregiver or from us. So, but instruct them to teeth twice a day. And it is very important to use soft toothbrush. If instead of soft toothbrush, if we are using the hard toothbrush, it will cause injury and damage, then lead to pain for the patient. So instruct them to use soft toothbrush. And if there is any toothpaste is remaining in the oral cavity after oral care, it may cause dryness. So please instruct them to make sure there is no toothpaste left in the mouth after the oral care. And if the patient can rinse, if for mild candidiasis, we can advise rinsing the mouth with homemade saline, and we can advise soda bicarb solution every 4th hourly or 6th hourly for mild candidiasis. If the candidiasis is more, then we can prefer oral medications. Then while taking care of the mouth, you should give special attention to the tongue. The candidiasis, sometimes the candidiasis white patches will appear on the roof of the mouth mucosa and all. And it is also present. Some patients it is also presenting in the tongue also. So tongue to be brushed with a soft toothbrush after the oral care, and instruct them to take plenty of fluids. And for dry mouth, dry mouth is a major indication for developing these oral complications. So we can advise the patient to take one small piece of pineapple and ask them to keep in the mouth, and it will act as a salivary stimulant. So the patient can control dry mouth. So pineapple is a salivary stimulant. We can advise this for dry mouth patient. If the patient is having any lesions or wound or thrush in the oral cavity, it will painful. So according to the condition of the patient, we can suggest this. Then instruct them to remove the dentures at night time. Before going to sleep, they should remove the dentures. Then we already discussed a procedure for a patient requiring assistance. If the patient can brush or the patient's upper limbs are okay and he can sit with support, just assist the patient in oral care. Provide all the articles needed for the oral care. Just assist him. First of all, explain the procedure to the patient. We should explain what is the importance of doing oral care or twice daily brushing. What is the importance for that? We should explain. Then for every procedure, we are providing privacy. Then preferably use. Provide semi-fowler's or fowler's position. If not, contraindicated. If the person can sit, you can give fowler's or semi-fowler's position. And for preventing the contamination of cloth and all, place a towel under the chin over the bedding. Then pour like that. And if the patient can rinse the mouth frequently, then encourage them to do. They can do it with soda bicarb solution and normal saline. Then after procedure, remove and clean the equipment, wash your hands, then document the time, what solution we are used for, then condition of the oral cavity. Is there if the patient reported pain or there is any lesions, and that all points should be included in the documentation. So time, solution use, condition of the oral cavity, patient response, these points are very important. If the patient can rinse, encourage them to rinse with soda bicarb solution or homemade saline. This is what we discussed for a patient who can do oral care by themselves. But now we are going to discuss about the procedure for a terminally ill patient. Usually, what are the articles we are using for doing oral care for a terminally ill patient in hospital settings? What are the articles that we are usually using? Any of you, please? Common articles we are using in the hospital setting for giving oral care for a terminally ill patient or the unconscious patients. What are the articles? Okay, let's see. We are mainly using artery forceps for cleaning the oral cavity, holding the cotton. Then tongue depressor we are using. Yes, ma'am. Okay, we are using. Okay, artery forceps we are using, tongue depressor, gauze pieces for cleaning the oral cavity. 0.9% normal saline we are using, small Macintosh to avoid contamination of bed and clothings, then face towel to wipe the face, then clean water after care, then swab sticks and kidney tray. These are the main hospital things what we are using for giving oral care for a terminally ill or unconscious patient. But if the patient is discharged to home, there is no artery forceps there. For normal saline, we can advise them to make homemade saline. But for cleaning the mouth, there is no arteries forceps. That time, what we will advise is we can advise them to take spoon or ice cream sticks. They can use spoon or ice cream sticks instead of artery forceps. And like this picture, take a spoon or ice cream stick and take a clean cotton cloth or gauze piece. If the gauze piece is available, we can use that. Otherwise, get a clean cotton cloth, wrap it like this. Just the spoon handle, just wrap it like this, and we can use it as a artery forceps. Then we are using homemade saline instead of 0.9% normal saline. Then if there is Macintosh is present, we can use. Otherwise, we can advise them to take a plastic sheet. Then face towel, clean water, swab sticks if available, they can. For kidney tray, we can take whatever it is available at the home. And the procedure for a terminally ill patient, first of all, explain the procedure to the patient. We know the patient is terminally ill or unconscious, but we don't know how extent the patient can hear. So before starting procedure, whatever the patient is terminally ill or unconscious, we should explain the procedure. Who are you and what you are going to do. So explain the procedure to the patient and provide privacy and place a small Macintosh with a face towel under the head, then semi-fowler's position and head turn towards the side. If the semi-fowler's means we can keep the patient around 15 to 30 degree up like semi-fowlers. In hospitals, we have uh, side, other equipments for positioning. If the patient is in home, we can use pillows for positioning this patient. By using the pillow, give a semi-fowler's position and the head turn towards the side to prevent aspiration. So while we are providing oral care, there is a chance of retaining a fluid on the oral cavity. So to prevent this aspiration of this fluid, we should place the head turn towards the side. Then use a padded tongue blade to open the patient mouth and separate. Previously, we made a spoon. Like that thing we can use as a tongue blade to open the patient's mouth. And soak cotton balls in homemade saline and goes out excess water. Before cleaning the mouth, you should squeeze the excessive water from the cotton or gauze or cotton cloth. Otherwise, it will cause aspiration. And before starting the oral care, like this picture, you should assess the oral cavity. You should assess for any wound or is there any candidiasis. You should assessment is very important before the oral care. And for separate the lips and teeth, we can use this spoon sticks. And this is the procedure. And the common lubricants used for lip care is the main important point in this, after doing this oral care with normal saline, you should clean the oral cavity with normal water. Otherwise, there is some taste changes will happen. So after the oral care, you should clean the oral cavity with normal water also. And lip care is very important. Lubricate the lips using swab stick. And for lubricating the lips, we can use liquid paraffin, coconut oil. In some ways, they are using coconut oil for lubricating. Then ghee oil, they are using Vaseline. We are mostly using liquid paraffin and we are using white petroleum jelly. In some patients, they are using coconut oil, ghee oil, and Vaseline. And next is a video on this care of oral care for unconscious patient. Let's watch it and come back. Then we can discuss it on.
closed. Mrs. Sophia is her caregiver. Miss Shanti is the attending nurse.
How is Anna doing today?
She slept well yesterday.
Oh, that's great. Can we clean Anna's mouth now? It is very important to keep her mouth clean daily. Even though she cannot respond, she can listen to us. I am Nurse Shanti. I am here to clean your mouth, Anna.
Articles required for mouth care. We need 1 Macintosh or a plastic sheet, 2 towels, 2 spoons or toothbrushes without bristles, a gauze roll or cotton cloth strips, a glass of homemade saline, a glass of normal water, Vaseline and swab sticks, a pair of clean gloves, a torch and a kidney tray. Raise the head end of the bed or keep 2 or more pillows under the patient's head. Take the Macintosh and the towel and place it behind the patient's head. This is to prevent soiling of bed sheets. Then spread the second towel over the patient's chest to prevent soiling of the dress. Wash your hands and wear clean gloves. Take 1 spoon and a gauze roll strip. Cover the handle of the spoon with the gauze roll and tie it. This can be kept for opening the mouth. Take the other spoon and wrap the same way. Here, the other end of the gauze or cloth should be kept long. There is no need to tie it. Take the wrapped spoon and keep in between the chewing surface of the teeth on the right side to open the mouth. Never use your fingers to open the patient's mouth, as they may bite your fingers. Take the torch and look for any white patches, redness, ulcers, bleeding, foul smell and discharge. Take the other wrapped spoon and dip it into the homemade saline or salt water. Squeeze the gauze well to avoid aspiration of solution by the patient. Remember, while cleaning, you should keep the other end of the gauze piece inside your hand to prevent accidental fall into the oral cavity. Clean the left side of the teeth, first lower chewing surface, inner side and the outer side. Then clean the lower front teeth, inside first and then outside. Then clean the upper teeth, inside and outside. Discard the used gauze after cleaning each surface and take a new gauze. Wrap it over the spoon and dip it in normal water. Squeeze well and clean the entire area so that the salty taste will subside. Then remove the wrapped spoon and keep it in between the teeth on the left side of the patient's mouth, and similarly clean the right side of the mouth as shown earlier. Clean the tongue from outer to inner parts, first with normal saline and then with normal water. Discard the used gauze. The cleaning procedure is over. Now apply Vaseline to the lips. Remove the towel. Replace all articles in its proper place and provide a comfortable position to the patient. Take-home messages. Mouth care is an important part of daily patient care to prevent infections and foul odor. Remember to keep the patient's head tilted to one side during the mouth care. Do not use your fingers to open patient's mouth. Squeeze off excess water from the gauze before doing mouth care. Clean the mouth with clean water at the end of mouth care. To know how to make homemade saline, watch the video Dressing Materials and Solutions.
Ma'am,
I think it's clear right now how we are taking care of a terminally ill patient or an unconscious patient. We can move to next. Is there any doubts in oral care? Any doubts? Next, we are discussing about the care of eye. Next, we are discussing about the care of eye. The eye care is very important for an terminally ill or unconscious patient. And before starting the procedure, we should explain the procedure to the patient and provide comfortable position. If the patient can whatever is comfortable for the patient, we can give comfortable position for that patient. Then wash our hands or ask the caregiver to clean their hands and clean the eyelids and eyelashes with wet swabs. We know if the secretions is very dry and we are trying to remove it from a cotton, dry cotton, it may cause some injury or damage to the eyelid or eyelashes. So never always ask them to never use dry cotton or swabs for cleaning. We are every time we are using wet swabs to wipe the lids, and we are wiping from from inner to outer canthus. Like third picture, we are cleaning from the inner canthus to the outer canthus and use one swab for one stroke. For after one stroke, you should discard that and take a new one. And if the patient is having a infection on his right eye, then we should clean the left eye first. The infected eye we are cleaning at last. So it is very important, if the patient is having any infection, then clean the uninfected eye first, then the infected eye. And documentation is very important. As like any procedure, we should document the time, what is the patient response. We can use normal, some of them are using homemade saline and normal water for this. You can choose according to the availability and comfort of the patient. And these are included in home eye care. Then care of nose and ear. Sometimes we will not give special attention to the ear of a bedbound patient, but it is very important because it is also a pressure point in terminally ill and long-term bedbound patients to develop pressure sores. So before starting the procedure, you should explain the procedure to the patient and the caregiver. And our main aim to remove the secretions from the nostrils or from the ear. And here also we are using wet wash clothes or cotton applicators. Before applying or inserting these into the nose or ear, we should wet it in on the saline or water. Saline or water, normal saline or water according to the availability we can use for this. And the main point is after cleaning that, you should check for any dirt accumulated behind the ears and in front of the ear. Mainly we are forgot to check we will not check the behind the ears. So it is very important to check for any dirt accumulated in the ear. Then collection. If there is excessive collection of ear wax, sometimes the patient may experience hearing problems. And if the wax is excessive and it is hard, please don't try to remove by yourself. They need a ENT consultation. For some small amount we can remove. Don't try to remove the hard wax from the ear or nose. They need an ENT consultation. And care of hair. Like all procedures, just explain the procedure to the patient and just help if the patient can't able to move, just help the patient to move his or her head towards the edge of the bed. And after placing the head to the edge of the bed, you should remove the pillow, otherwise it will cause pain for his neck. So after placing the head to the edge of the bed, just help them to remove the pillow. And we should place a Macintosh or rubber sheet or plastic sheet, whatever it is available, just make it on place it on the pillow to avoid the contamination and all. And before starting the procedure, insert a cotton ball into the ears to prevent the water entry. If the water injuries happen, sometimes patient may develop some ear infection and all. So before starting the procedure, you should insert a cotton ball into the ear. And already we place the patient head to the edge of the bed. If the Macintosh is available, just place it under the head like this. Just fold the sides of the Macintosh or rubber sheet and keep it under the neck of the patient, and the end of the Macintosh should be placed in a bucket to receive the water. Just place a Macintosh like this. The picture showing that is, just place it, hold the side, and this end of this Macintosh should put on a bucket. We should place a bucket on there to receive the water after cleaning. And we can give thorough wash with the soap, or if the patient is having shampoo, we can use that. We are giving thorough washing of the hair. And after cleaning, rinse thoroughly and dry the hair. And if the patient is okay, dry the hair into 2 or each side. It is according to the comfort level of the patient, whatever it is. And one thing is, you should remove the cotton balls from the ear after the procedure. For hair care, just place the patient to the edge of the bed, remove the pillow, then place a Macintosh, make it as like this. Just hold the sides and the end should be in a bucket to collect the water. And after that, just dry the hair and remove the cotton balls from the ear. Actually, when we are giving this type of hair care for that patient, the patient may feel more comfortable, and it will stimulate sleep and all. The main thing is patient may feel excessive comfortable. And next is about the nail care. We know nail care is very important because most of if the patient is bedbound for a long time or the patient is terminally ill, there is a chance of developing dry skin. Most of our patients will develop dry skin during the time of terminally ill due to poor oral intake of fluids and all. So if there is a dry skin, there is a chance of development of itching sensation. So if we are not cutting the nails properly, the patient will try to resolve the itching. So that time there is a chance of development of scars, and sometimes it may lead to development of pressure sores. So nail care is very important for terminally ill patient because they are mostly suffering from dry skin. Dry skin may cause itching, and for itching they will start scratching on the skin. That small abrasions will future abrasions will lead to development of pressure sores sometimes. And if the patient is having diabetic and all, there is a chance of developing as a wounds. So before starting the procedure, you should explain the procedure. What is the importance of providing nail care for terminally ill patient? Patient is terminally ill or bedbound. So terminally ill or bedbound. So we should explain the importance. Then assemble all the articles needed. What we needed is a bowl and nail cutter, bowl with the warm water and a nail cutter, and place the rubber sheet under the patient hand or leg to avoid contamination. And before starting the procedure, we should keep the patient finger, allow the patient finger to soak for 5 minutes. It will allow easy removal of the nails. It will soften the nails while we are soaking into a hot warm water. It will soften the nail and we can easily remove the nail ends and cut free edges of the nail and encourage the caregiver to provide nail care. While we are demonstrating the nail care, it is very important to teach them how to do it next time. But if we are not doing it properly on regular intervals, otherwise it will cause skin damage. So it is very important to encourage the caregiver to provide nail care. And next is about the bed bath procedure. Like hair care, we should give, like every procedure, we should maintain privacy throughout the procedure and explain the procedure, why we are giving bed bath. If the patient is bed bound and there is a wheelchair access or available, wheelchair access bathrooms are available, we can shift the patient to washrooms. Otherwise, we can give bed bath from the bedside itself. For that, maintain privacy, explain the procedure for the patient because it will improve the comfort level of the patient. And we should gather all the needed equipments before starting the procedure. Before starting the procedure, the temperature of the water should be checked by the patient, and it is purely on the patient comfort. Just check the temperature before starting the procedure. If the patient can sense it, then ask them to check the temperature. Otherwise, you can check it by your hand and then start the procedure. And make sure the patient is placing near to the edge of the bed. Otherwise, the caregiver may exert over stretching and straining, and this will lead to back pain and all. So, before starting the procedure, you should check the temperature and make sure the patient is placing near to the edge of the bed. Otherwise, it will cause over stretching and straining of the caregiver. Then, while doing bed bath, the main thing is to only small area of the body should be exposed and bathed at a time. If we know how to do bed bath, and while doing bed bath, please don't expose the patient completely. Whatever area you needed to clean, that only you should expose. And we will start with, if we are doing the procedure from the right side of the patient. If we are standing on the right side, keep the patient to the right side of the bed, to the edge of the bed. Then first we will start from the face. In face, we will give eye care, oral care, nose and ear care, that all we will give. Then next is the neck. Then if we are standing on the right side of the bed, first we will clean on the left hand, then chest, then right hand, then abdomen, like we are cleaning. First neck, then proximal end, then chest, then the distal end, then chest, then the proximal end. And you should make sure to remove the soap completely from the body. Otherwise, it will make dryness of the skin. And usually we are doing first cleaning the upper part of the body before the lower parts. We are cleaning it from the less contaminated to more contaminated. And for a human body, we are considering as upper body parts is less contaminated than the lower parts. So from the upper parts, we are starting the cleaning, then to the lower parts. And during the procedure, we can immerse the hands and feet of the patient in a basin of water, and to promote thorough cleaning of the fingernails and toenails. In between, we can immerse the hands and feet on the warm water. And while doing bed bath, the one important point is while you are giving bed bath, during that time you should thoroughly inspect the skin, especially at the back of the body, because the patient is terminally ill or bedbound. If they are remaining for a long time for in a supine position, there is a chance to develop pressure sores. So we know the pressure points. So while doing bed bath, we should inspect the pressure points to find out any early signs of pressure sores, and apply moisturizing cream and massage and by using a moisturizing cream, we can massage it for 3 to 5 minutes. It will increase the blood circulation, and through that we can prevent pressure sore. And after giving bed bath, back care is very important. These procedures are all familiar with all nurses, so back care is very important. In back care, we are giving special attention to the pressure points. We know if the patient is in supine position, these are the pressure points. So while after giving bed bath, we should give special attention to the bed pressure source. If the patient is sideline position, we should give attention to the pressure points. So like that, give special attention to the pressure points while giving back care. We can give back care every 2 hourly with the position changing. And we can during the cleaning we are not recommending rubbing, dry the skin by rubbing. We are preferably drying the area by patting, and after that we can apply moisturizing cream and we can give back care for back massage for 3 to 5 minutes. And earlier I said massaging helps to increase the blood supply and to prevent pressure sore. Okay, what do you mean by pressure ulcer? Pressure ulcer is otherwise known as decubitus ulcer, bed sore. Okay, what do you mean by pressure ulcer? What is the main reason for developing pressure ulcer? I think we all are so familiar with pressure ulcers. It is an easy question for all of you. What is a pressure ulcer? Okay, pressure ulcers is a localized injury to the skin. It is a localized injury to the skin and other underlying tissue over a body prominences as a result of prolonged unrelieved pressure. It is mainly due to a prolonged unrelieved. If the patient is bedbound for a long time on a single position, there is a chance of developing pressure sore on the pressure points. These are some of the pictures, examples of pressure ulcer. Mainly we are seeing if the patient is in supine, we can saw pressure sores in the sacral region. It is very common, and in the heels also we can see. How can we prevent bed sore? Actually, bed sore we can prevent bed sore by through doing proper position changing. For if the patient is bedbound and we know the patient is more prone to develop pressure ulcers. So for that patients, we should do position changing every 2 to 3 hours. It is compulsory. And if the patient is a wheelchair bound patient, ask the patient to do a push-up in every 15 to 20 minutes. If the patient's upper limbs are okay, they can take push-ups by themselves. And if they can't, just ask them to relieve the pressure. If they are in wheelchair, just ask them to relieve the pressure at that area. That is enough for them. And if the patient is bedbound, we can change the position every 2 to 3 hourly. And incontinence. Bowel and bladder incontinence is the major problem for developing pressure ulcers. And if there is incontinence of bowel and bladder is there is continuous contamination or wetting of the perineal area, sacral region and all, that will decrease the skin integrity and patient may easily develop pressure ulcers. So management of incontinence is very important. If the patient is having urinary incontinence, then if incontinence is there, the next option is continuous bladder drainage. If they are willing for continuous bladder drainage, just put the patient on Foley's catheter or silicone, whatever it is available, just manage it. And if the patient is having bowel incontinence, just assess the cause of that incontinence. If in some bowel incontinence patients, while position changing and pressure exerting time, they can evacuate more fecal matters. So that's why we can give regular suppositories and all, we can adjust that also. So manage bowel and bladder incontinence. Then special surfaces. Special surfaces means we can give air mattress, water mattress, pillow and cushions. Air mattress and water mattress we can give, but the only one thing is it will not prevent pressure sore. It will prolong the formation of development of pressure sores. So the 2 hourly position change is very important. In addition to that, we can give air mattress, water mattress, and for positioning the patient, we can use pillows and cushions. If the patient is on sideline position, make sure that we are placing a soft pillow or any soft cushions in between the knees. Otherwise, there is a chance to develop pressure sores on that area. So that is very important to place a pillow or cushion. Then nutrition, hydration and exercise. Nutrition means if the patient is bedbound or terminally ill and they can't take anything orally, decreased nutrition may lead to poor skin integrity. Then decreased fluid intake will cause dryness of the skin. These all adding to the formation of pressure ulcer. And exercise. Exercise is also very important for this patient. So prevention of bed sore for preventing position changing. For bedbound patient, every 2 to 3 hourly position change is compulsory. And if the patient is wheelchair bound, ask them to relieve the pressure every 15 to 20 minutes. And if the patient is having bowel or bladder incontinence, we should manage that also. Then in addition to this position changing, we can provide air mattress, water mattress, pillows and covers. Then nutrition, hydration, exercise, these are very important. And massaging. Like earlier we said in back care, we can give massage with liquid paraffin or white petroleum jelly. While giving massaging on that pressure points, it will increase the blood circulation and it will promote circulation to that area and prevent bed sores. These are the air mattress and water mattresses. And prevention of bed sores is we are listing down in the skin. In skin, S means supporting surface. Supporting surface means make sure your patient get pressure relief on proper supporting surface. If the patient is on a wooden cot, then they are more prone to develop pressure sores. So make sure there is a supporting surface. If the patient is bedbound for a long time, please provide a air mattress or water mattress, what it is available. You should give that. Then skin inspection. Next, X stands for skin inspection. In skin inspection, while we are giving back care or bed bath or skin care, we should inspect the pressure points area. That is regular skin inspection required all over the bony prominences. If the patient is in supine, we know what are the risk areas for pressure ulcer. So skin inspection is very important. If we can identify the early signs, we can prevent formation of pressure ulcer. Next is keep moving. That is, already we said 2 to 3 hour position changing for bedbound patient is very important. That is frequent posture changes. Then is incontinence or moisture control. If the patient is having bowel or bladder incontinence, mainly in bladder incontinence, we should keep the patient in continuous bladder drainage. And nutrition. N stands for nutrition. Nutrition means we should make sure the patient is getting adequate nutrition and water intake to prevent further damage of the skin. So prevention of bed sores coming under in these headings: skin. First S is supporting surface, skin inspection. K, keep moving. I stands for incontinence or moisture control, and N stands for nutrition. And I already said exercise is very important. If the patient can tolerate, ask the caregiver and teach the caregiver how to do active and passive exercises for the patient. If we are not doing or moving the joints for a long period of time, there is a chance to develop contractures, foot drops and wrist drop. To prevent these complications for prevent contractures and foot drops, you should instruct the caregiver or teach the caregiver how to do active and passive exercises. And this is according to the tolerating level of the patient. First, you should ask the patient, then decide what the patient can do. And all joints need physiotherapy. If the patient is pain-free, then we can do it. Before starting the procedure, we should, if the patient is not responding, and while doing the exercise, if the facial expression shows some pain, then you give special attention to the pain first. Then go for the exercise and educate the family about the importance of exercise and how it's prevent the joint stiffness and all. You should give. And next is about the catheterization. the patient is bedbound and some of them will experience incontinence, some of them have retention and all. So the bedbound patient's main health complication is to develop pressure sores. So catheterization is very common in that type of patients, and usually we are using Foley's catheter for urinary catheterization. We are inserting it through the urethra and to the bladder. We are inserting it into the bladder through urethra to drain urine. And these are the different parts of a catheter. At the tip, there is a bladder opening. Catheter, there is a bladder opening. This is a Foley's catheter. At the tip, there is a bladder opening. Through this opening, the urine is draining from the bladder to the urobag. And near to that bladder opening, there is a balloon. Balloon is helping for retain the catheter in the bladder. And there is the tubing, and there is a bifurcation, and one is balloon inflation port and another one is urine drainage port. The urobag we are connecting to the urine drainage port, and the urine is draining through it. And balloon port is using for inflating the balloon. And these are the main types of catheterization that we are usually seen in palliative care patients. The size of the types of catheterization coming under indwelling catheterization. Indwelling catheterization means the catheter tip remains in the bladder for a long time. We are putting the catheter tip into the bladder for 1 month, 2 weeks, 3 weeks. That is indwelling catheterization. Next one is clean, intermittent or self-catheterization. In that, the indwelling catheterization is a sterile procedure, and the clean, intermittent self-catheterization is a clean procedure. In clean, intermittent catheterization, we are intermittently insert a nail cath. The fourth picture, the nail cath into the bladder to drain urine. It is a clean procedure. The patient can do it by himself at the home care settings. And last one is condom catheterization or external catheterization, the third picture. The third picture is a condom catheter. Here we are not inserting anything into the bladder. We are just only collecting the urine that is drained out. There are 3 types: indwelling catheterization, clean, intermittent, and external is condom catheterization. In indwelling catheterization, there are mainly 2 types. If we are reaching the bladder via urethra, it is urinary catheterization, indwelling. Otherwise, if we are reaching the bladder via suprapubically, if there is any tear or injury to the lower urinary tract or urethra, we can approach the bladder. If the patient is having retention, and we can approach the bladder via suprapubically. So these are called as suprapubic catheters. If we are reaching the bladder via urethral catheters, and this is suprapubic catheters. These are the main 2 types of indwelling catheters. Another one is intermittent. In that, we are putting catheters intermittently for a duration of time. And external or condom catheters, here we are not inserting anything into the bladder, just we are collecting the urine. And for a patient with catheter, when we are discharging this bedbound patient to a home, we should teach them how to take care of the bladder. We should instruct them to change the catheter from 3 weeks to 1 month. Within 28 days, the catheter to be changed. And perineal care is very important. Perineal care means in hospitals, for perineal care, some of them are using betadine solution, providing iron solution, and normal saline and all. In home care setting, we can instruct them to clean the perineal area below the umbilicus to the mid-thigh. Just instruct them to clean with soap and water. While they are taking bath, or if the patient is at home, just clean from the below umbilicus to the mid-thigh by using soap and water. That is meant by perineal care in home care setting. And keep the urobag cap always closed and below the waist level. If we are placing it on the bed or below the bladder, it will cause urine backflow. So advise them to keep it below the waist level. Then instruct them to empty the bag when it is 3/4 is full. And intake of fluids. If the patient is on a catheter, continuous bladder drainage, advise them to take at least 2.5 liter to 3 liter in 24 hours. Otherwise, the person may develop urinary tract infections. So, advise them to take 2.5 to 3 liter over a 24 hours. And just observe for the flow of urine, any color change or any pus or any dark colored urine, you should inform the healthcare professionals. And encourage the patient for daily bowel movement. Why it is very in bladder care, the bowel movement is very important because if the patient is having chronic constipation and all, there is a chance to develop accumulation of these hard stools in the upper rectum, and gradually due to the bacterial functions, there is a leakage of fluid through the sides of the rectum and lead to spurious diarrhea. In these type of patients, this hard stool may exert a pressure on the bladder, and that time some patients may experience catheter leakage. So bowel pattern is very important in catheter care. If the patient is suffering from chronic constipation, the hard stools may exert pressure on the bladder neck, and by this pressure the catheter leak may experience. So it is very important. Then after each urination and defecation, instruct the patient to clean the perineum with the soap and water and clean from the cleanest to less clean area. Then before and after the procedure, you should clean the hand. Then next is about the bowel care. Till now, we discussed about the bladder care. For bladder care, instruct them to take 2.5 to 3 liter of water. Perineal care is tell the patient to clean from below the umbilicus to mid-thigh with the soap and water. And please instruct them to change the catheter within 3 weeks to 1 month. That is, within 28 days, they should change the catheter. Next, we are going to discuss about the bowel care. We know in bedbound patients, they are not moving for a long time. So there is a chance of developing constipation is very common in that patients due to reduced food intake, lack of exercises, privacy, and some of the medications also cause constipation for that patients. So encourage the patient for bowel movements daily. And if the patient wants to go for toilet, then we can, if the patient is able to sit, then we can shift the patient to the toilet. Otherwise, we can, if the patient can sit, we can provide a commode chair near to the bedside. The important thing is we should give privacy. Privacy is very important. If the patient is in a common ward or in a open area, while providing these facilities, we should make sure the patient is getting enough privacy for the defecation. And encourage the patient for daily bowel movement, and encourage them to take high fiber diet. Adequate fluid intake is necessary, and if they can do, encourage them to do regular exercises. These are coming under bowel care. And if the patient is comfortable now the patient is bedbound, and for that we can use bed pans. It is the important point is to provide privacy. Privacy is very important. And if they are comfortable with the commode or lavatory for defecation, we can shift them in the wheelchair, or then we can sit in the toilet. And in spurious diarrhea, in some of the patient, if the patient is having chronic constipation, as I earlier said, if there is any chronic constipation, the hard stools may accumulate on the upper part of the rectum. And above this hard stools, due to the bacterial action and all, there is a fluid leakage through the sides of these hard stools, and patient may experience diarrhea. But it is only due to that constipation. It is not actual bowel opening. It is the leakage of fluid through the sides of the hard stools. This is called as spurious diarrhea. So if when a bedbound patient or a patient with less mobility complaining of diarrhea, we can suspect spurious diarrhea. If it is a spurious diarrhea, we should ask them for any chronic history of chronic constipation. If there is any chronic constipation, there is a chance of spurious diarrhea. And this management, it is very common in bedbound patients. Spurious diarrhea is very, very common in bedbound patients. Most of our patients will experience presenting it as spurious diarrhea. And the management include when a patient is experiencing diarrhea after a history of chronic constipation, we can do rectal examination. I think everybody is aware about rectal examination. We are using our index finger for doing the rectal examination. If we are getting a free space in the rectum, it is called as balloony rectum. Balloony rectum is the significant findings in spurious diarrhea. If the patient is having spurious diarrhea, we can feel a vacant space in the rectal region, and the hard stools is located above the rectal area. So if the patient is having diarrhea and the rectal wall is there is a vacant space, it means the patient is suffering from spurious diarrhea. And if the hard stools are, we can touch the hard stools, just try to remove the hard stools manually. That is digital rectal evacuation we can do. After passing that hard stools, a patient's bowel habits may regularize. Then for this, if the patient is having spurious diarrhea and while doing rectal examination, I got a balloony rectum. So I am suspecting spurious diarrhea for this patient. This patient is already have a history of chronic constipation. For that patient, we are giving high sodium phosphate enema. Usually, we are giving sodium phosphate enema on the lower rectal area. But if the patient is having spurious diarrhea, the hard stools are located in the upper part of the rectum. So, for this, we are using 16 French suction catheter. 16 French suction cath we are using. Take a 16 French suction cath, lubricate it, and ask the patient to lie down on a sideline position. Then advise them to take a deep breath. We are just lubricate the tip of the suction cap. Just slowly insert the suction cap to the rectal region. Where we feel primary obstruction or a hardness, just stop there. Give 1 phosphate enema. Then wait for few minutes. Then again reinsert the suction cap. Then we can give the second phosphate enema. Like that, we are managing the spurious diarrhea. Because the stool is in the upper rectal part. So, if we are giving enema on the lower rectal part, it will not affect. So, through the help of 16 French suction catheter, we are inserting this enema to the upper rectal region. And next is about the bowel care. And next is about the nasogastric tube feeding. In some of the patients can't take orally while in the age of at the time of terminal ill or at the bed, if the patient is bedbound. So nasogastric tube feeding is very common in these type of patients. We know this is a process of feeding with nasogastric tube that is inserted to the mouth, inserted to the nose through pharynx, esophagus, and the stomach. From nose, it goes to the pharynx, then esophagus and the stomach. Mainly, we are using 16 and 14 French Riles tubes for feeding. And the care of nasogastric tube is very important because before starting the procedure, you should perform hand hygiene. And for feeding the patient, give Fowler's or semi-Fowler's position before feeding. If there is backresters are available and we have adjustable coats, then we can adjust it with that. But if the patient is in home and they don't have an adjustable bed, place some pillows on the back of the patient to give Fowler's or semi-Fowler's position. Before feeding, you should make sure the patient is in Fowler's position. And before opening the tube, you should pinch the tube to avoid air entry into the stomach. Then, before starting the procedure, you should make how to make sure the position is just aspirate the content. While aspirating, if you are getting food particles or secretions, we can confirm it is in the it is in the stomach. And if while aspirating, if we are getting more than 50 ml of food contents, then skip the feed. We don't give that feed. If while aspirating, if we are getting more than 50 ml, just skip the feed and uh, just skip it. Then food items is thoroughly grind and filtered. Otherwise, it will block the nasogastric tube. Then the recommended amount of rice tube feeding is 200 to 250 ml. Actually, we are giving the time interval is ideally 2 hourly. 2 hourly, we are giving nasogastric feeding, and the recommended dose of food is 200 ml to 250. And this in this 250, 50 ml is plain water. 200 is our feed. We can give homemade feeds also, and 200 is our feed, and the remaining 50 is our plain water. 25 ml we will give at the starting while starting the procedure, and after feeding we are giving remaining 25 ml to clean the or clear the tubings. And keep the it is very important to keep the patient for at least 30 minutes in the same Fowler's position after feeding, because the patient's esophagus, the glottis is not here, the rice tube is there. So there, if when we are suddenly moving the position to 0-degree angle, there is a chance of regurgitation of food particles and may lead to aspiration. So for rice tube feeding patients, if we are not treating it properly, there is a aspiration pneumonia more in this type of patients. So we should keep the patient for at least 30 minutes. Then provide oral care and keep the lips moist. Oral care is very important for rice tube feeding patients. Patient is on nasogastric tube feeding. We should give every 2 hourly oral care. At least we will give oral care after every feed, and we should moisturize the skin, lips also. And there is a chance to develop pressure sores due to the adhesive tapes. If so, periodical changing of the adhesive tape is very important for rice tube patients. If we are not changing it periodically, there is a chance to develop pressure sores on the tip of the nose. So usually we are attaching the rice tube adhesive tapes like here. So instead for that, we can attach it to here also, to the cheeks, like that we can manage. And other thing is, if the patient wants to taste the food, just give one drop of that food to his tongue. So that time the patient can feel the taste. And this is all about the care of bedbound patient. Next week, is there any doubts regarding these slides? We can discuss it.
Ma'am, there is a question.
Yes.
Given liquid diet every 3rd hourly. I think they answered, I think this.
Okay, that is the answer.
Is there any doubts? You can put it in chat box. Otherwise, you can unmute mic and you can ask. Yeah, participants.
Actually, it is a vast topic. That's why
It's very, ma'am.
there is no time to interaction during the procedure because I want to finish it by 1:30, right?
Yeah.
Yeah.
No doubts for everyone. Thank you so much, ma'am. It's a good session. Actually, it is very useful for care of bedridden patients to maintain home and hospice also. So it's very a good session. Thank you so much.
Thank you.
We can.
Thank you, ma'am. Thank you for the insightful session. And dear participant, we can wrap it up. And